Good morning, students. Good morning, presenters. Welcome to everyone to our second day of orientation for the Faculty of Medical Sciences. My name is Rihanna Ramutasingh. I am the Administrative Assistant to the Deputy Deans of the Faculty. As you guys are entering into year one, the Deputy Dean is Professor Ezen Walker, who you all would have met yesterday. And a gentle reminder that for all of our presentations today to keep your microphone on mute unless you are asked a question and you're required to speak, right? First on our program, we have a presentation by the Medical Sciences Library. This is going to be conducted by the staff of the library, Mrs. Ayana Cumberbatch and Mrs. Nala Dwarka-Batiste. So I welcome them this morning. Good morning to our librarians.
Okay, great. Good morning.
Good morning.
So I am not Niala Dwarka-Batiste. I am Niala Dwarka-Baggett.
And I am Ayana Elaine Cumberbatch.
Welcome to the Medical Sciences Libraries, Services and Resources. So what I'm going to do now is jump right into our presentation. So our session today deals with the pandemic and our on-site services. Once again, welcome to the Medical Sciences Library, also known as the MSL. So our new normal is now about 18 months old. Yes, we know COVID has changed the world, including the way the library functions, but rest assured that we are working remotely for our users. Today, we are introducing you to the resources and services available to you during the time that the library is physically closed, which is now, and what to expect when the library opens. So as I just said, the library is not physically open due to the pandemic. However, you can interact with our library staff via chat, which is our MedLib chat service, and email via our Ask a Librarian service, both of which are available on the library's webpage. During the pandemic, we have a number of services available. You may visit the website for searching for electronic resources such as databases, ebooks, electronic journals. We have document delivery services where you can request research articles. There is a research portal for you to use, which is ULink. And as mentioned before, we have our Ask a Librarian email form on the website as well as the chat. Using the website is very, very important. Always keep in touch with what is on the website. When the library opens, be sure to wear your UE student ID at all times. You must not borrow or lend your IDs. It is strictly prohibited. And on entering the library, you must show the ID to the UE security officer at the library's entrance. You must sanitize, do a temperature check, and wear your mask when entering the library. Social distancing is also important. Practice safe 6 and keep 6 feet away from persons at all times. Curbside borrowing is currently suspended until the library opens. You can visit the website for more information as this service changes. How many books are you allowed to borrow? Undergraduate students are allowed 10 books and serials. We have a booklist collection, which is also called the reserve collection, and a maximum of 2 items can be borrowed from here. So the reserve collection contains your booklist items, whereas the general collection contains books that are allowed to be loaned for 14 days. Online payments. There is an online payment link on the MSL webpage to pay for printing, which is topping up your printing account called the Pharos account, photocopying, and you may also use the facility to pay for overdue fines. When the library opens, visit our accounts unit when you need to conduct transactions face-to-face. Returning books. So when you borrow books, after the time that you are allowed, During the time when you are allowed to borrow books, there is a blue book bin located outside the library's entrance, and this can be used to return library material beyond normal library hours. Your return items will be in quarantine for a 72-hour period, 3 days, and then checked in. All fines accruing over that 3-day period will be cleared. The library has collaborative spaces. When the library reopens, there are seminar rooms and a Zoom room available for booking and use.
And would you? That's all right, yes.
Cell phones are to be used in vibrate mode or silent mode only. You may use your cell phones inside the library for emergency and patient care use in 2 designated areas. And when you visit the library, we will point this out to you. The extras that we offer are free Wi-Fi, charging stations, and computer lab services. The library will soon be doing training sessions on our resources and services, so do not fear. We will be in touch with you via your respective schools and stay abreast via the FMS social media outlets for news updates coming out of the library. And do remember to sign up when alerts are sent out. So I will now hand you over to my colleague who will share with you the second part of this presentation.
Thank you, Niala. Before we leave, I would like to take the opportunity to share a video with you, which captures all the information that my colleague just outlined to you. Please understand that you all will be privileged to be premiering the video to you. It is the first that it's going to be aired, and we're so very proud of the hard work that you put into it. What this video will do is outline what the library offers, as well as give you the opportunity, if it is you weren't able to grasp everything in this presentation previously, to view what it is we have in store for you at the Medical Sciences Library. So, on behalf of Ed and myself, excuse me, on behalf of Head and myself, we would like to welcome you to the Faculty of Medical Sciences. Thank you.
The Medical Sciences Library in the Faculty of Medical Sciences is located at the Eric Williams Medical Sciences Complex in Trinidad and Tobago. Officially opened in October 1989, our services are aimed at meeting the needs of the Faculty of Medical Sciences teaching and research programs. These include medicine, dentistry, pharmacy, veterinary medicine, advanced nursing education, and optometry. Registered users of the campus libraries can access these resources electronically. In addition, our library's wealth of resources and services are available to the wider university, and special accommodation is also made for external users. There are 4 seminar rooms, a 24/7 reading room, collaborative spaces, as well as a postgraduate study room. Our multimedia computer labs are equipped to facilitate activities related to the library's information literacy and training programs. Reading rooms are also available at off-site locations at the Sangre Grande Hospital and the Cuba Hospital and Multi-Training Facility. Our library has an extensive collection of books and journals, both electronic and print. It also houses a West Indian medical collection and a Pan-American Health Organization collection. A number of subscribed and free databases are available on the Medical Sciences Library portal. These provide coverage on a range of topics and areas of specialization in alignment with the curriculum and research agenda objectives of the Faculty of Medical Sciences. Our teaching and research support includes reference and research, Ask a Librarian, and MedLib Chat, borrowing for print and multimedia resources, access to electronic resources, access to databases and e-resources, document delivery, collection development, support for course proposals and faculty book lists, and the reserve collection. There is ongoing library orientation for students and staff, as well as thesis checking and consultations. In addition, we offer librarian liaisons for faculty members for current awareness, research and reference service, relevant workshops, and training sessions. Librarians also support faculty in scholarly communication. In our library, you can access the internet, wireless network services, photocopying, printing, and scanning. Our reading rooms provide online access to all resources at remote sites. Some of our other services include booking an online appointment with a librarian, online payment for services and fines, and borrowing and curbside pickup. You may also book an appointment to use the library, book a seminar room with a maximum of 4 persons per room, or make a booking to use the computer lab with a maximum of 10 persons. For more information, please visit us online. You can also get in touch with our circulation desk by calling 645-3232 extension 5201. We look forward to serving you at the Medical Sciences Library.
Thank you very much. And over to you, Rihanna.
Thank you very much for that presentation. It was very informative. You know, there are some benefits to us having to do everything remote now. One of this is an example. This is orientation here. You know, students get information firsthand in front of their face. At this point in time, we will continue along to our next segment, which is on communication issues of the deaf and hard of hearing and an introduction to sign language. This is going to be facilitated by Mrs. Hamilton Lejeune. Mrs. Hamilton, are you on? Can you hear us?
Yes, I'm here. Good morning.
Hello, good morning, and how are you?
I am quite well, thanks.
Okay, so welcome to our orientation for the Year 1 students. I welcome Mrs. Hamilton Lejeune. She's a medical social worker with the North Central Regional Health Authority for the past 13 years. She holds a Bachelor of Science degree in social work with a minor in social policy and a master's in clinical social work from the University of the West Indies. Her professional and volunteer work with the community of persons with disabilities spans over 15 years. She has served on the executive of various disability-related organizations and currently volunteers as a sign language interpreter with the local chapter of Disabled Peoples International. Quite a big hat. Good morning again, Mrs. Hamilton, and I hand over to you.
Ms. Dwarka. Good morning, everyone. I'll start to share my screen, but in the meantime, I would like to allow the person who would be supporting me in this presentation to introduce himself. Are you all seeing someone on the screen?
And yes, we are.
Right. So can everyone see my presentation? I just want to make sure my share screen is being seen.
Yes, it is.
Thank you. So I'm going back in now. So good morning to each and everyone again, all 438 of you, and welcome, I would say, to my future colleagues, because as was mentioned before, I'm a medical social worker. So I would be seeing you all now, and most likely I'd be seeing you all in Year 4 again, when you all are doing community health with Miss Helena Joseph. I would be seeing you all again because you may have to interview a social worker. So that takes care of our first slide. So before we continue, I just want to give you a brief overview about the two presenters today. My name is Anessa Hamilton Lejeune, and you all would have heard my qualifications already. But I'm also a wife of a deaf adult for the past 2 years, and he would have just introduced himself to you, and most likely you all did not understand a thing he said, did you? My husband's name is Jamal Lejeune. He would have acquired deafness at the age of 7 due to meningitis, which we call post-lingual deafness. He's currently reading for his diploma in agriculture at the University of Trinidad and Tobago. He's self-employed as a farmer. He's the former acting president of Trinidad and Tobago Association for the Hearing Impaired. He would have left office in November of last year. He's currently the vice president of Trinidad and Tobago Disabled Peoples International. He's a current board member of the Consortium of Disabled Organizations. He's the co-founder of Deaf Sports Organization Trinidad and Tobago. He's the co-founder of Voice of the Deaf and Hard of Hearing Trinidad and Tobago. He's my husband. He's a father, and he's also a sign language tutor. That's a lot of information, right? So some of you may be asking, why is she telling us all of this? Because it will explain why from now on I need to be signing throughout this entire presentation. As long as Jamal is here, it is my responsibility as an interpreter to ensure that he's included in this session. By including sign language in this presentation, I would have covered 5 of the 8 general principles of the United Nations Convention of the Rights of Persons with Disabilities, which was ratified by Trinidad and Tobago in 2015. And of course, I could give you all a wonderful lecture about deafness. I could show you all a few signs, but I don't believe it will give you all a true representation and a true understanding of the issues with communication in the deaf and hard of hearing community. So I asked Mr. Legion to come in so you all will get a first-hand experience. And when you all ask questions, Mr. Legion will be answering them. So what we want to do in this presentation is do an overview of deafness globally and locally, to define what deafness is, to introduce you to what we call the models of deafness and the conflicts that arise with the different approaches. We want to address the issues of communication due to misconception about the deaf, some basic communication tips, an introduction to sign language, and of course, we will be answering your questions. For this presentation, what we would ask you to all to do is to open your cameras. I'd ask you all to open your cameras because Mr. Ligier would require you. He wants to see you because he's been part of the presentation. He can't hear you, so he needs to see you. And we would ask you all to use the chat option to answer the few questions we'll be asking you along the way. And I want to encourage you, ask anything. We have nothing like a stupid question in these sessions. This is new information to some of you. So we have nothing like a stupid question. And we welcome your feedback. Cool? So if everybody is understanding what I'm saying, I'm expecting to see 440 yeses come into the chat right now. All right, so it's loading up already, which is great. So we expect a highly interactive session. You can put your questions in the chat and we will be discussing it as we go along. So what is it like on the road of life to meet a person who's a stranger who opens up his mouth and talks a line at a rapid pace and you cannot understand the look in his face because it is new and you're lost in the race? You have to be deaf to understand. So let me do that again for someone, for you to experience what I just said as a deaf person. How was that experience? It looked like madness, right? Okay. So Dr. Willard Marsden was a deaf university lecturer in 1972, and he would have coined this, it's a poem actually, and I actually only used one verse here, but he spoke about the various experiences he would have had being a deaf person and navigating a hearing world. So you're meeting a stranger who's talking to you, and he's talking and you have no clue what he is saying. And only a deaf person would understand what that means, or a person who doesn't follow the language that the presenter is giving. Right. So question for everybody. When you hear the word deaf, what's the first thing that comes to your mind? And be honest, we have, again, no wrong answers. What's the first thing that you think about? Nobody's answering. Are we all messaging in the chat?
We have answers in the chat at this present.
Right, right. Loss of hearing, disability, can't hear, can't hear. unable to hear, can't hear or speak, unable to hear, Daredevil, the superhero. The person can't hear me, hearing impaired. Laugh out loud, yes. Switch at birth. Anyone saw Deaf You on Netflix? And there's a new movie called CODA, C-O-D-A, which means Child of Deaf Adults. That's also a movie on Netflix that we have now that gives you all an experience of being a hearing child of deaf adults. Right, beautiful. So some people have a very good idea of what deafness is. We also have a quiet place, a silent voice. Very good, thank you. So what exactly is deafness? According to WHO in 2020, they say that disabling hearing loss is hearing loss greater than 40 decibels in the better hearing air in adults and less than 30 decibels in the better hearing air in children. So let me give you an example of what that would mean. So on top here, where you're seeing the tap, the leaves, and the bird, that is what a person or what we call normal or typical hearing loss would be able to hear. So your hearing range or the decibel range is between 0 to 120. So a person with severe or profound deafness would not be able to hear that tap, but they would be able to feel the vibrations of a lawnmower, they would be able to feel the vibrations of a truck, and they would be hearing some residual sound, a helicopter, an airplane. So disabling hearing loss, they would be able to hear the phone if they have on a hearing aid. Yes? So those of us who would have what we call normal hearing, we may be able to hear that bird, but we'd be able to tune it out. And I could tell you as a wife of a deaf husband, I hear that tap. So if he turns on the tap and the place is quiet and he doesn't turn it off properly, I'd be able to hear that tap dripping. And for me, I tell people, now I hear for 2 people. So I would tell him when leave on the pipe, no, I took it. I said, go and see. And he would see that the tap is still running. So before we continue, we want to clarify some terminology. So when you see the word common DEAF, deaf, it means the medical condition of not being able to hear. But when you see capital D, deaf, is a person with hearing loss, but they identify with the cultural aspect of being deaf. It is regarded as their race, as their gender, as their identity, as they see themselves as a marginalized group. And these persons will sign and interact with people with the same experiences. So I would have told someone in the deaf community, you would see 2 people who say they are brothers, and it would be 2 different races. But because they are deaf, they consider that person more of a family than their hearing relatives who cannot sign. Right. So let's clarify. Deaf is a person, as you would have seen in the audiological picture there, a person with less than 40 decibels in the better hearing air, a person with little to no speech due to the onset and the severity of their hearing loss, and a person who relies on sign language to communicate, and they use a sign language interpreter. There's also persons who are hard of hearing who would only be able to hear specific sounds at specific frequencies. So we have some friends who hear sounds that are very high, and we have friends who hear sounds that are very low. Right? A person who's hard of hearing may have speech impairment because they cannot hear themselves, so they don't know how they sound. And a person who is hard of hearing would rely heavily on lip reading. They normally don't use sign language, but some of them use sign language and speech as their main form of communication. Some also write. Anything unclear so far? And we're talking about an anime.
No, everything is clear.
Anime with a deaf person. Okay, cool. Please write down the name of the anime and put Jamal watch this because he likes anime. On a global scale, the WHO said that there are 432 million adults and 34 million children with deafness. And they said that 1.1 billion young people, that is between the age of 12 to 35, are at risk of losing their hearing due to exposure of noise when they're partying, when they're liming. So, of course, we are Trinidadian people, so we lime. And we can't lime without music. Sometimes we drive in our cars, we rock back, and the music is blaring. Sometimes we sit with our earphones in our ears for a prolonged period of time. We do not give our ears a break. So WHO is saying because of how we enjoy ourselves, we are now at risk. So 1.1 billion young people are at risk of losing their hearing. So by 2050, 1 in 4 persons will be experiencing mild to profound hearing loss. That will be 700 million people worldwide. So if we look at it, we have 440 persons in this room. So according to WHO, if we are not careful, 110 of you could experience mild to profound hearing loss. And those persons would be coming to you, the doctor, for medical support. So according to the Trinidad and Tobago census, we have 6,217 persons who live in Trinidad who have some measure of hearing loss. Of course, the deaf and hard of hearing community say that is not true. It's more than that. So right now, what Dretch is planning to do is to engage in research to find out the real number. So I would have spoken about the models of deafness before. So let us explain. The 3 major models of deafness are the medical model, the social model, and the cultural or the human rights model. So the medical model, which you all would know, and which you all will get to know, says that deafness is a functional loss, a handicap, an impairment, and it needs medical intervention and rehabilitation to improve a person's quality of life. So the medical model would use terminologies like disabled, hearing impaired, deafness, and they would believe that the best way for this person's improvement of life would be to use hearing aids or to undergo surgery to get a cochlear implant. The social model of deafness says that the deaf suffer disability not because they can't hear, but because their limitations placed on them by their own environment. So the social model will now focus on what is needed within the environment to ensure that the person with hearing loss has an equal quality of life when compared to a person who is hearing. So a person who follows the social model will use deaf, deafened, hard of hearing, and people with hearing loss. So the social model will focus on the onset of the hearing loss and the detection to be able to have a better functional life. The cultural model recognizes the beauty of what we call deafhood. So when we use that term, people are like, deafhood? Yes, deafhood. Young deaf persons use this word. And now we have an emergence of persons who are deaf who are now standing up and speaking on behalf of their community. So no longer they are allowing persons who do not experience what they experience to speak on their behalf. Right? So most times we hear the term hearing loss. A person who follows the cultural model of deafness would say deaf gain or acquired deafness. So they do not see deafness as a loss of something. They see it as, I got something and I gained it. It's a new experience to me. And persons who follow the human rights or the cultural model they focus on sign language development because that is their main means of communication. Am I going right, Mr. Leger? Right. So, Mr. Leger, which term do you use? Are you deaf or are you hard of hearing? So Mr. Leger is saying that he vacillates between the two. And why is that?
Most time I use pen. Most time I use pen. Sometimes I will be hard of hearing for the deaf community. For the hard of hearing community, they will say I am deaf. So I use sign language more. To understand sign language. But in the deaf community, I use speech more. So I am both.
Did you understand what he said? Faith has this really confused look on her face. So yes, was Mr. Leger clear for everyone?
I understood most, but not all. That's why I had the confused look.
All right. So Mr. Leger was saying that he is medically profoundly deaf, but culturally he uses both. To the hard of hearing, they would see him as deaf. But for the deaf community, he can interpret for them. So he actually is hard of hearing, right? And as we said, because of the age of onset, Joma would have lost his hearing at 7. So he would have had a command of the English language. So if he has to interpret for a deaf person, he can vacillate between both words. So what are the major issues with communication with the deaf and hard of hearing? So let us define one time. What is communication? So the Merriam-Webster Medical Dictionary, which I'm sure was on your book list, is the exchange of information between two individuals through a common system of signs, symbols, and behavior. So if I am signing and you are speaking, there is a slight probability that we could have a problem with communication. And if there is miscommunication, there is a possibility that if I'm giving you information, you will not understand. So you can misdiagnose. We could have poor management problems. And when you're talking about adherence to medication, we may have an issue. So the Journal of the American Board of Family Medicine says deaf persons and hard of hearing persons have problems with healthcare utilization patterns and specific significant communication difficulties with physicians, and they have misunderstandings about their disease and treatment and recommendations. So to doctors, they are a silent group. I would have done research on the experiences of the deaf and hard of hearing in 2015, and I would have spoken to 12 persons who have either diabetes or hypertension, and most of them don't know how a person gets diabetes or hypertension. So sometimes doctors will decide, okay, a deaf person comes to me, this is what I will do. All right. So here's the problem. A person who is deaf from birth would have a low English reading level, and that's because they were not fully taught to read English. A person who is deaf from birth, their first language is actually sign language. So one of the problems we had was, and this is an example given by Zavov Amiedo, a doctor would say, you may need surgery. But a deaf person would believe the person says, you in may need surgery. So the doctor is saying, we're not sure, you may need it. But the person is saying, the doctor say, I will have surgery in me. We have a phenomenon that has been researched widely about deaf is equal to dumb. And Schwartz, who is a deaf lawyer, said that most doctors have this attitude towards deafness, that deaf and dumb is an appropriate term. Mute and the ability to speak, it shows a lack of intelligence. So remember, we talked about the medical model of deafness, which says that there is an impairment or a lack, right? And just one thing to clarify, the term mute. So when you mute your TV, what happens? You hear nothing. You hear nothing. If you have ever interacted with a person who is deaf, you would know that they are very loud. They don't know volume. So using the word mute is actually not accurate, because a person who is deaf can actually use sound. They just don't know that they are using it. The term dumb, because we have two meanings of the word dumb, the deaf don't use it, because I remember Jamal has a jersey, deaf and smart. Because when we hear dumb, we think dumb, right? So because of these issues, we have sometimes a lack of respect coming from the medical personnel towards the deaf. And that could really affect how information is communicated. Right. So in the medical model, we have terminology such as hearing loss. But in the cultural model, they will say acquired deafness. In the medical model, we will have hearing impaired, and hearing impaired is a general term, so it would not take into consideration what we explained before. The deaf need this for communication, the hard of hearing needs this for communication. When we use the broad term of hearing impaired, their communication needs are now generalized, and we do not focus on what specific support they would need to understand clearly. So the human right model, they would say, I'm deaf or I'm hard of hearing. There's a term that we like to use in Trinidad, normal. Normal. What exactly is normal? We don't have a clear view of what that is. So we would say normal hearing, but in the cultural model, we say typical hearing. Because we know that there are people who have normal hearing who don't listen. Right. So we are talking about the terminologies. And people say, come on, that is semantics. That's really important. Yes, it is. Because when you meet a parent of a child who has hearing loss, and the first thing we say is your child will not have a normal life. What's the opposite of normal? Abnormal. So it starts on a negative connotation one time. And when we use the word loss or impaired, it says substandard, broken, defective, problematic. So we have already shared with this parent negative, 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 negative. I have met with some parents, they found out their child is deaf, and when they're finished speaking to the doctor, they're crying. I lose my child. No, your child right here. No, I lose my child. I don't know what to do. So I have now to sit with them and work with them now to understand your child can have a normal life. It just would be a different kind of normal. So when we talk about the new normal, we're talking new normal long time. Have nothing to do with COVID. So some doctors say, well, all deaf people should be able to lip read, right? So I will just talk slow and they will read my lips. Doesn't happen as beautifully as we think. So traditionally, the deaf were not taught to focus on sign language. They were taught to focus on what we call oralism and lip reading and speech. But if you do not have access to sound, and without the help of sign language, learning English through writing and lip reading, it's not really successful. They will not understand clearly. So let me do an example. Read my lips. What did I just say?
I thought you said move.
So somebody saw move.
Book.
Move.
What is that?
Move.
Move. I heard book. What else?
Boom.
Boo. What else?
Boy.
Boy. Okay. So Jamal is saying paw. So that is just to explain that one thing I said, and watch how much interpretations of that one thing came off my lips. I actually said more. So when we think that lip reading is clear, no, only 30% of English speech sounds are visible on our mouth. So speech reading actually requires us to watch the body language, the facial expression, and it relies on the deaf person to have knowledge of the topic that we are talking about. So if they are coming to a doctor and they have no understanding of the medical terminology, that's not going to help at all. Lip reading is going to make things. So Jamal wants to ask a question. So Jamal would like to know, is that normal for you guys, the lip reading and not understanding? No. Right.
I can't read lips to save my life. So
Someone would say, well, if a deaf person come into the hospital, let them come with a relative, and that will make it easier for everybody, right? No. Speaking with a patient's relative doesn't take into consideration that there are people who are deaf and hard of hearing who are in families that don't sign. Also, if there is sign language in the family, some of them don't know how to translate medical information to sign language. So there is a possibility that we would have problems with sharing this information. Yes, we have families who would grow deaf children and no one in the family signs. Yes. Also, what I have seen happen, if there is a hearing person in the room, the real patient is left out of the discussion. So what happened to him? And the patient is right there. What happened to him? What happened? And the deaf patient is saying, I'm feeling sick for 3 days now. And if the parent don't know, the relative don't know, the whole discussion is with the relative, and the patient cannot verbalize what's happening. So in some research that was done in Trinidad in 2009, this social worker gave some experiences. A child said, I went to the doctor with my mom. She was not able to interpret. She told the doctor what happened to me without even talking to me. And Jamal is saying sometimes a doctor needs an interpreter. And sometimes the doctor talks straight to the interpreter alone. And they're talking and going on, and the interpreter is just there. And they give you very little information. And I would say, so all that talking you're doing with the doctor and that little bit of information you give me, right? So this child would have said, I felt at a loss because my parents were not able to communicate my feelings. And a child said, I get frightened because I was given an injection and I did not know why. So everybody probably saying now, telling me. What's that? Okay. So, you're probably asking, okay, so what do we do? Right? So, according to your Oxford Handbook of Clinical Examination and Practical Skills, I believe this is one of your holy grails. It advises a doctor who is talking to a deaf patient to make eye contact, don't shout, speak clearly and slowly, and do not exaggerate your oral or facial movement. So they're telling you, don't depend on lip reading. And I would tell you, this is good information. Make eye contact. They're looking at you. Don't shout. So let's do that. How does that come across to you?
Aggressive.
Aggressive. What else?
Mean.
Mean. All right.
Offensive.
I wasn't even focusing on your mouth. I just see the hand.
That you were upset.
Right. So sometimes people think if I shout at a deaf patient, they will hear. So when you shout, it comes across as aggression. And Trinidad people, when you're aggressive to me, what I'm going to do? I'll get back aggressive to you. So there's a breakdown of communication one time because one person thinks, well, I just trying to help. But sometimes what happens is communication requires both persons to be on the same page. So if I'm shouting, thinking it's clearer, what I'm receiving is aggression because I can't hear it. When you speak very slowly, it becomes, look at Jamal's face, it becomes more confusing for a deaf person. Right. So you didn't understand. So people would say, talk slower. It doesn't help. One thing we would suggest is always ask the patient how they prefer to communicate, because not all deaf and hard of hearing persons use sign language. Ask them, how do you communicate? Most times a deaf person coming to the hospital will walk with a book and a pen. And remember, we spoke about their command of the English language is not as clear as a typical hearing person. If a patient comes with a relative and they ask to speak to the doctor alone, please respect that. In most cases, the culturally deaf adults live alone. Their parents may not be a good historian of their medical condition. And this would lead to poor history taking and possibly a misdiagnosis. Some parents actually bring their hearing children to interpret. So we have to look at age-appropriate discussions. So I had an experience with a man who is 50 by now. And when I was speaking to him for my research, he has 2 adult sons, but he goes to clinic with his mother. So when he comes back from clinic, she just tells him, continue to take your tablets, that is all. He does not live with her. And again, you'd have been talking to this doctor for about 15 minutes. And all you're going to tell me after is, continue to take your tablets. So I asked him, why don't you carry your son with you? No, I prefer my mother. But the mother has no information to give him. So what happens is, he doesn't know if he is managing his hypertension properly. Right? As a deaf adult, they're entitled to their privacy. I would have been training at another medical institution and a deaf person came in to get some medical attention. And because of what his problem was, he told the doctor, not her, no. I want to talk to a male alone. And the doctor was like, no, she needs. I was like, no, respect him. I walked out of the room because I was like, most likely I don't want to know. And the deaf community is small. As you all have seen, 6,217, and research has shown maybe 2,000 persons in that community sign. Because I am married to a deaf man, there's the assumption that if I know, he knows. Because confidentiality in the deaf community is understood a little differently to what we know as confidentiality. So information sharing is good for them. For us, some things should remain private. Right? If a patient tells you they prefer to write, please keep your jargons simple and explain the diagnoses clearly. You could even draw for them to fully understand what is happening. And you know, doctors always get the tail end of the joke that you all can't write properly. So make sure that when you all are writing, so Jamal says some of the writing looks like Japanese. So when you all are writing, make sure that your handwriting is clear and be very clear about possibilities with your with medicine. So instead of saying you may need surgery or you may need to do another test, say maybe. So we would not have the issue of may, meaning month, versus possibility, right? Of course, we would suggest that you use the services of a sign language interpreter. There are 2 interpreters at Eric Williams Hospital, myself and Ms. Karen Lianos. Each RHA should have our own interpreting network. So when you go on your rotations, ask about that. If you have a deaf patient, what happened? And of course, we would suggest that you learn sign language. In Jamaica, if you are doing your MBBS or your medical degree, you cannot graduate unless you learn medical sign language. So we are hoping that soon happens in Trinidad and Tobago. So thank you for your attention and your participation. Any questions?
I have a question.
Sure.
During lockdown, I started learning sign language and I realized that there is American Sign Language and English and British Sign Language. And I realized that Trinidad has its own sign language as well, but there isn't a lot of information about that online or readily available. And I wondered, how can someone become involved in the community and how can they learn Trinidadian Sign Language?
I'm sending that question to Jamal one time.
Okay.
So a lot of people learn online and they would learn sign language online. That's good. But as a deaf person in the community, stop looking online, don't look in a manual. Talk to one of us. We are the best manual you could learn. And we would teach you sign language that we use. Most signs that you would learn online, you all would not be able to use it because there's different contexts and cultural concepts. So American Sign Language do have a sign for black cake, cricket, carnival. They don't have it. So right, when you want to learn Trinidadian Sign Language, all you have to do is line with the deaf. And they teach.
So considering that, considering that I haven't been able to line with the deaf, I know that it can be kind of annoying for a deaf person to try to teach I guess a typically hearing person sign language. I know that sometimes it's offensive. I don't know, like, can you clarify whether it is offensive or if some people don't mind and some people find it annoying?
So Jamal is saying no. Deaf people, they are very motivated and excited to teach sign language to especially to medical personnel. Why? We need medical personnel to sign in Trinidad and Tobago. We want Trinidad to be the first in the Caribbean. Jamaica has doctors, teachers, medical students, everybody learns sign language. But other places in the Caribbean, no. And we would like some more here. Any other questions?
Hi, Miss. Great day. I have a follow-up question to Cherise regarding Jamaica having people to teach their students before they graduate sign language. Does Trinidad have anything in place as courses with MBBS and just that faculty to teach us, you know, probably like classes on the side sign language, as it is not required for us to graduate with it?
Medical faculty will have to explain if they have something. I don't know about it, so don't quote me on that. We have persons who teach it. Jamal teaches sign language. we would have taught 3 medical students before. So one is a doctor in Tobago, Dr. Chadband, and he uses sign language. He uses sign language. We had 2 other students who learned it, and one of them called me the other day and said, I finally got a deaf patient and I couldn't remember nothing. So I need a top up. I need a refresher to learn again.
The faculty does offer some kind of course based on my friends who are currently in the program. But I wondered, can you guys provide your information so that we can contact you if we want personal lessons? Because it's been a struggle.
The information is already up there. Am I still sharing screen?
Yes, but it's blocked. I don't know if it's just me, but how you're appearing, you and your husband, it's blocked, so I can't see the slides.
Okay, so you would have to change the view because from what I'm seeing, the screen is being shared right now. So let me give my number, 739-3094. Any more questions? If there are no more questions, we'll spend the next 3 minutes giving you all a few signs. But still ask your questions.
Good morning. I have a question. So I wanted to know, you said out of these 6,217, I believe that people in Trinidad and Tobago, only 2,000 know sign language. So how are we as physicians,
Go ahead.
Physicians to communicate with the rest of people who don't know sign language and are deaf or hard of hearing?
So research has said that we don't know how they came up with that number because the persons who did that research are not Trinidadian. What we have is that's why we always say, ask the person how they communicate. We have friends who are hard of hearing. And if you sign for them, they're like, help me here, I don't know what you're saying. So they would come with pen and paper and they would write. So that's why we always say, ask first. I have met deaf patients. Hello, my name, there's a shush. Nope. Write for me. Yeah?
Okay,
always ask. Always ask.
Okay, thank you.
Yeah. Any more questions? All right. If it's possible, I can send an abbreviated version of this presentation to Ms. Dwarka for her dissemination to you all. Most of the information here would have been from my research for my master's in 2016. So I would just take out some of it and send it to you because it's closed for publishing right now. So we have 1 more minute left. So I would like to thank you all for being such a wonderful group to communicate with. As again, you may see Jamal and I again. You'd see me definitely if I am still here when you all are in year 4. And we want to encourage you all, yes, learn sign language, but we want you all to go away with the notion that deaf persons require specific communication when they are coming to meet with a doctor. So always, please ask. Jamal, anything to say? So you want to teach them 2 words before we leave? So I'm being told, come out the share screen. That is what I can't sign. So hold on. So Jamal says, come out the share screen because I want to see everybody.
Miss, can you show us how to say thank you so we can thank him?
Right.
By language.
Yes. Thank you. All the same. So yeah, T. Thank you. So your palms facing inward from chin outward. So he's teaching you hello. That's not all aboard, that's hello. So how are you? And I will tell you this. If a deaf patient sees you do that, they get excited and they start to rattle. So you had to sign one time. Little bit, sign language. Yeah. So Jamal, just before we close, Jamal will do it again. So he will sign it again. Thank you. Hi. Hello. How are you? Okay. And this is how we clap. Since we can't hear the sound anyway, this is how the deaf person will clap.
Wait, sorry, could you do the how are you again? One more time.
How? So put it together. How are you? So if I wanted to ask all of you, I would say, how are you? Huh? So thank you all, everyone.
That's beautiful. Thank you.
Yeah. So have a wonderful session. And again, I would see you all if you all ever have to come Mount Hope.
Come to say goodbye.
Bye. Trinidadians are natural signers, eh? So we know this. And this one, all you know that. Coming back. And
Crazy.
Later.
Okay, so thank you so very much to Mr. and Mrs. Lejeune. I hope I'm pronouncing your name properly. Our students have such wonderful feedback here in this chat. I am seeing the enthusiasm. Unfortunately, we do not have a sign language course in the faculty, but perhaps it's something I could look into for, future workshops or collaborations. Once again, you shared your number with students, so I'm sure students can get in contact with you, Mrs. Lejeune. Students, don't forget that at the end of the entire orientation, at the end of the week, there's a survey link that is attached in the program. You all can click on the link and rate each of your sessions, which was your favorite, etc., etc. Up next, we have Dr. Rian Extavor. Dr. Extavor is a pharmacist by training. She has worked as a lecturer at the School of Pharmacy in the University of the West Indies, St. Augustine, and she's currently the program manager of the Caribbean Regulatory System for Medicines Regulation under the Caribbean Public Health Agency, which some of you will know as CARPHA. Dr. Extavor graduated from the first class of pharmacy students from the faculty and hold postgraduate qualifications in clinical and administrative pharmacy and in pharmacovigilance and pharmacoepidemiology. She's a Fulbright alum who has served on national and regional advisory committees for pharmaceutical regulation and policy. Her past experience includes pharmacy practice, pharmacy education, consulting in pharmaceutical policies, pharmaceutical systems assessment, medicines utilization, pharmacovigilance, and post-market surveillance with research in rational use of medicines, pharmacy education, and pharmacovigilance. With the current global pandemic, Dr. Extavor has led operational initiatives of the CRS, including technical reviews of the World Health Organization approved COVID-19 vaccines and a regional network for pharmacovigilance and post-market surveillance. I will now present to you Dr. Extavor.
Good morning. Thank you, Rihanna. And thank you to the Faculty of Medical Sciences for inviting me to speak on this topic. And pharmacovigilance, it's an emerging field. It's something we've been working on, but we didn't call it that before. So some previous terms have been used, and I will touch on a few of them. So let me know if you can see my screen as yet. Yes, great, thanks. And so just going through briefly, I've tried to bring out the highlights that gives us the foundation for pharmacovigilance. And then I want to bring some examples of what's happening around the world and where we are seeing important aspects for safety. So this relates to medicines, vaccines, and health technologies that are used primarily in humans, and the ways in which governments and regulatory authorities think about safety before something gets to market and while it's on the market. So I'll go through scope, purpose, some general concepts, and I want to highlight the roles and responsibilities of healthcare workers in particular because of the audience that we have. And as you go through your training and your program, each of you will encounter medicines or pharmaceuticals in some way or manner and utilize in the sense of either prescribing, administering, dispensing, storing, distributing. So in some aspect, you will have an important part to play in either ensuring safety or quality and integrity throughout the use of a product. So I'll start with some history. And in 1937, you may or may not be aware of this story. Sulfanilamide was an antibiotic tablet available also as a powder, and it was used to treat streptococcus infections. And the S.E. Macedonil company in the US decided they wanted to create a liquid form to make it more available or easier to use instead of a tablet, because sometimes tablets are difficult for persons to swallow. And then formulating the elixir, the compounding pharmacist used diethylene glycol. Now, diethylene glycol is what we call antifreeze. At the time, they thought it was a useful solvent. So instead of using an alcohol base, they substituted with this solvent. At the time as well, there were no legislations or laws or regulations that required medicines to undergo animal testing or to show that it was safe or to show what are the toxic effects before they are allowed for use in humans. The elixir was made and distributed in September, and by mid-October, they were seeing an increased amount of reports of hospitalization and deaths amongst users, and overall 105 persons died. The sad part about this story, unfortunately, we learned from the lesson, but some people have lost their lives, was that the absence of regulation to say this is what will happen if a company causes or something was made and was inappropriately made and it caused harm to persons. Because there were no regulations, the only penalty applied at the time was that the company was charged for mislabeling because they called it an elixir and it had no alcohol. So that essentially is a slap on the wrist. But the next year, the US Congress passed the Food and Drug Act, and that is where we started seeing regulations coming out requiring efficacy and proof of safety for medicines and other health technologies used in humans. Another story, this is on the other side of the Atlantic, that's mostly happened in Europe. And thalidomide was a drug that was marketed heavily towards helping women who are pregnant get to sleep or to help control their nausea. So it was an antiemetic and a sedative. At the time, there were no requirements for proof of safety and efficacy in the European countries where it was marketed, and several women used it. One doctor noted that he was seeing children being born to his patients without fully formed arms or fully formed limbs, and that's called phocomelia. And he published a case series in the Lancet, and that started a cascade of other physicians coming forward and reporting that they noticed this, and when they checked back to see what the pregnant woman used, they found over 10,000 babies had been born with this deformity following the use of thalidomide while their mothers were pregnant. The drug at the time was not marketed in the USA because the US had passed that Food and Drug Act. But what they learned, again, another unfortunate lesson, is that sometimes harms are difficult to predict before they're used at the time. And in order to prevent harms, we need to get information about the safety and the effects of a medicine or even a vaccine, as well as, and now they're considering it for certain medical devices. But it's important to know the harms that can happen beforehand, but also when the drug is on the market, what are the potential harms that can be caused, which ones can we expect, and which ones will we learn from. That joke was sweet though. Right, so the key lessons that came out of these is that we want to properly test medicines before they're used in humans or animals, and government regulations are going to be important for that. You'll hear these three words repeated a lot: quality, safety, efficacy, and those are three pillars of ensuring that what is approved is working, is efficacious, that it's safe, it does not cause undue harm, and it's of good quality. It's consistently made to do what it's supposed to do.
Mommy, let me tell you the joke. What happened now?
Regulators are responsible for looking at studies about the medicine, but also for having reporting systems that help identify these effects. We do have to note that some groups are more vulnerable to certain effects of drugs than others, particularly the older adults, pregnant and breastfeeding women, and children. So all of these things have to be taken into consideration so that actions can be put in place to minimize the risk to populations. I've put together this overview because it really simplifies the complexity of approving a medicine or a vaccine before it's marketed. So at one stage, we have to look to see what happens at the chemical level, at the lab level. How does this chemical act or react in certain conditions? As well as they have to provide information as to how it acts in animal studies. Only when it passes that stage to show its beneficial action as well as key toxicity information, then they move to trials in humans. And those are 3 phases. In each phase, the amount of persons involved increases. It does not stop at the proof of effect in humans, but regulators also have to look at the manufacturing process, ensure that the facilities are well inspected and that the product shows it works or contains the active ingredient after it's made. So that's quality testing. In our part of the world, labeling is important because we import medicines from around the world. So that label has to be in English and there are other criteria that must be met. But those first 4 bars you're seeing are the first part. But once we approve it for market, the governments as well as those manufacturers have a role to play to see how that drug continues on the market, both in terms of maintaining its quality, but most importantly, its efficacy, if it continues to work as they expect it to work based on the trials, as well as the safety to show any adverse reactions that were not identified during the clinical trials. This graph just shows you the growing, the different phases I mentioned. So you'll see preclinical, that's the animal studies, that tells you about safety in animals, and that gives some basic information. And then as the phases of human trials progress, that drug does not move forward from one phase to the other if there's any major safety problem identified. And the number of persons involved in the clinical trials increases, because if you only stop at hundreds of persons, we will not get enough information about safety. So that's why a lot of trials involve thousands of patients, and vaccine trials involve tens of thousands of patients. Only when the regulator is satisfied that the data on safety and efficacy show a positive balance of the benefits and the risks would it be approved for use. But it does not end there. Because some medicines and vaccines are new in a population or may pose certain harms in certain groups, manufacturers are held to account for additional information. So, for instance, when it comes to the novel coronavirus and the vaccines, those manufacturers have to continue following up clinical trial patients. They also institute registries where they collect information on, let's say, if they want to focus on pregnant women at the time, and they will follow those women in terms of monitoring what happens to them. Or the registry could be related to persons with cancer who were given the vaccine. So different types of studies contribute to knowing more about that drug or that vaccine, even after we've had some initial information that satisfies us and says we can use it, but we'll continue to pay attention to what we're learning as we see more and more persons utilize it. This is a simplified version also for the vaccine trial process. I would not spend too much time on that, but it just breaks down as to how we can identify the best dose and what they look for. And in the case of vaccines, they are looking primarily as to the type of immune response and the proportion of persons who have that type of response, or the proportion of persons who contract the disease, and different markers. But although randomized clinical trials, those are well designed and those are the gold standard for looking at if a product can be used in humans, there are some things we have to keep in mind in terms of their limitations. First of all, they are not able to select all types of patients. They need to focus to get a result based on how it works in a particular condition. So many times, the patient selection is a bit restricted. You will not usually see clinical trials including pregnant women, very young persons like infants or children, or very old persons, also persons with multiple medicines or multiple conditions that may complicate the findings. They generally are not included. However, that makes it even more important to monitor these groups once they start using the medicine or vaccine. The study size would be limited in terms of the manufacturer or developer would have to cut off at a particular point in time. And the conditions are not like real life. In real life, persons go to the pharmacy, they may buy something over the counter, they may use alternative or natural therapies, they may skip some doses. So it's not reflective as to how persons take medicines on a day-to-day basis. Some of the endpoints are short-term, so they might tell us about a change in blood pressure, but they would not be able to tell us about long-term survival in the case of cardiovascular disease. The duration might be too short, so we don't have all the information that is necessary. But the good thing is that the regulator, in our case, the Ministry of Health, would have things in place where the manufacturers have to provide information going forward, particularly for something that's new and was not previously on the market, so that when they have longer term information or information as to when the product is used in the presence of perhaps alcohol or other drugs, that information feeds back into the regulatory system, and then labeling can get updated. So pharmacovigilance, so that sequence of what happens with medicines and approvals. It's to highlight that this area emerged so that they could find a way to minimize the potential for harm that can happen with medicines, vaccines, and other pharmaceuticals primarily. It's a way in which they identify serious harms and develop methods to prevent serious harms in populations. And a serious harm is where something can cause death or is life-threatening or causes prolonged hospitalization or results in a long-term defect or a congenital anomaly where a child we have a deformity that could have been avoided. So the information from the clinical trials that I spoke about still plays a part. That's part of pharmacovigilance. But also when the drug is on the market, we do have systems for spontaneous reporting and other types of studies that continue to give information on the risks involved. And then we would reassess what we call the benefit-risk balance. When the regulator decides to take action to minimize risks, they would have different approaches. So they can have public education to tell people how to use the medicines more safely. They may send letters to health professionals and say, dear doctor, this drug is restricted for use in this particular group. They may decide to suspend marketing of the product overall or withdraw certain batches from the market. So in order to make those decisions, the regulator still has to get information from the field, from the persons who would use the medicine or who are exposed to the medicines. I will just move forward with this one. This is an overview of a more expansive way in which pharmacovigilance fits into a term we call post-market surveillance. I would not spend too much time on this one because I want to go to show you the scope. So pharmacovigilance has been defined as science and activities that help us identify or detect harms, assess them, understand them, and to prevent adverse effects or other drug-related problems. So this diagram I have in front of you, at the top you see the acronym ADRs, and that's short for adverse drug reactions. A lot of the pharmacovigilance work involves identifying adverse drug reactions, reviewing them, assessing them, and determining which ones have been caused by a suspected medicine. But it also includes where we had medication errors occurring. So for instance, where a medication error occurred because someone couldn't transcribe another health professional's handwriting, that's a potential for errors. And that can inform an administrator and that says we may need a better way for us to communicate prescriptions so that we reduce errors in terms of transcribing from one person to the other. So that's part of pharmacovigilance. When you hear about fake medicines or substandard products, that is where the quality of the product is not optimum. It may be where a drug or medicine or vaccine was falsified in the sense that someone decided to fraudulently reproduce it, and instead of the active ingredient, because they're not the manufacturer, they put a substitute, they put something else in it. That something else could be harmless or it could be harmful. And if it's harmful, you will see certain reactions occurring. When we say it's substandard, it means that the active ingredient may be present. It was not that the manufacturer intentionally made it poorly, but somewhere along the manufacturing process, the quality of the product did not meet the standard we need to. For instance, if a particular tablet that's supposed to take 20 minutes to dissolve in the stomach crumbles before being administered, or it does not stand up in terms of good storage when it's supposed to, and is deteriorating, that's a cause for concern. So that's also activity that relates to pharmacovigilance. when we find some things don't have the effect it's supposed to when used appropriately, when persons abuse or misuse medicines, that's also within the realm of pharmacovigilance. And when we have interactions between medicines and food, or medicines and other medicines to drugs, or where you have a drug affecting a lab result, that's also work that falls in the realm of pharmacovigilance. So it's a very interesting field, and some persons choose to focus on specific areas. And in different countries, I know it's tempting to look at what you see in the media or on the news about one medicine that is regulated a particular way, or a decision that's made maybe in Europe or in the USA, and say, well, we should also do that. But we have to be careful, because what happens in the response of our populations to medicines can vary. We have different genetics, we have different diets, we have different traditions, and we use medicines differently. We may have different types of diseases and different protocols for prescribing. Also, we also have traditional medicines and different beliefs about the use of traditional medicines, and our supply systems vary. So generally, it's good to know what's happening externally, but it's not easy to apply what goes on. You can't apply a protocol as readily, or you can't apply a sanction as easily in your country, because we need to have that information to ensure that we're making a reasonable decision and not putting ourselves at a disadvantage by removing something that would work if we adjusted how we use it differently. So the national stakeholders are numerous, and I've used a diagram from the WHO safety manual for vaccine surveillance to show how complex, or how many different personnel can be involved in monitoring the safety of a drug. And when we start with Ministries of Health, in our case, the Ministry of Health is also the national regulator. Public health programs and pharmacovigilance centers get involved. There may be advisory committees that work on the data. Manufacturers also share information. Academics do research. Healthcare workers are very key in helping to identify serious reactions that happen with their patients, or serious events that tell you the product may not be up to scratch or maybe substandard. But there's also the role for media and recipients of those vaccines and users, because vaccines or medicines. And the COVID-19 vaccine concerns that are emerging are really being broadcast, some good, some not so good, some misinformation. So all these bodies have a part to play in helping persons understand what is the information that's fact-based and scientific. Unfortunately, we also have a sea of information that is inaccurate, and it means you have a role to play in discerning and evaluating and critiquing the information based on what you will learn as you go through your individual types of programs within the faculty. So I'll say in a nutshell, because this is really a simple list about the role of health workers, I want to say, don't take anything for granted in terms of the different disciplines you will learn. When you go out into practice, pharmacovigilance is one of the examples of an area that's very multidisciplinary. The preclinical sciences you learn, paraclinical disciplines, and your practice, this is one area that brings all of those aspects into play. There is nothing that is meaningless. Sometimes we forget that we work in the context of laws and policies. So when you are beginning to practice, and this may be some years away, but as you go through your training programs, You will be exposed to regulations, information or policies and laws. And there are some that are specific to how we monitor and register and regulate medicines and vaccines. So that's important for you to keep an eye on. It's also important for you to keep an eye on what's new and emerging, because there are a lot of new biotechnologies and the ways in which medicines and vaccines are delivered that we will be learning about. And when something is new, has never been used globally, the mRNA vaccines are such an example. The pharmacovigilance aspect has to be very prompt and very alert for anything that can happen so that we can find new safety issues. Critiquing information sources and content. Being able to search for the appropriate information is an essential skill set for all health workers. It does not matter which field you're in. You need to know what makes a good information source. And when you read that article, you need to critically ask yourself, is this plausible? Does this match what we know about this scientific process? Am I only seeing one perspective? Did they interpret this information correctly? So that skill set is critical. It's also important because you will be advising your patients both about the benefits and the risks that are known for a particular medicine or vaccine. So you need to be aware of the information as well. And finally, become familiar with the systems that exist. You may not know of where to report right now, but as you go through and you learn in your pharmacology classes or in public health, and as well as in some of the classes that relate to medical legislation or regulations, this is something that may come across, you may start learning about. So I've put up this cycle to show where you fit in. And if you look at the top right-hand corner, adverse events following immunization, that's the equivalent of a suspected adverse drug reaction. So that's the term that WHO gives it, AEFI. And parents and guardians, doctors, nurses, and different health workers in the community can detect these either directly, maybe it's an experience, it's an experience that they had themselves as a patient. Maybe it's something they see in their child after they received a vaccine, or as a health worker. So for instance, pharmacists are very approachable. They're easy to reach. You don't have to make an appointment to walk into a pharmacy. So let's say a pharmacist working, someone comes and asks, well, I got this vaccine and this happened. What happens next? It means that the more we empower our health workers to understand when to report an adverse event following immunization, we start to strengthen our own national systems, because that's just the starting step. When it gets to the ministry, there needs to be a step for investigation, analysis, causality assessment before the regulators can decide if it needs to be restricted in the group, if it needs to be stopped altogether, or if we need to decide we'll use smaller doses. But we as health professionals are important to that first step of knowing how to report, what to report, and what constitutes or what makes up an adverse event that we should at least notify within the hospital system or within the national reporting system. So at the end of the day, pharmacovigilance is asking, how do the benefits balance against the risks? As long as a medicine or vaccines benefit outweigh the risks, we say it's safe, well, relatively safe. There's nothing that's free of risk. Everything has its benefits as well as negative outcomes that are possible. But what pharmacovigilance does, it says, what are the negative effects? How common are they? How many people would they happen in? Are they mild, moderate, or severe? if they're serious or life-threatening, we need to pay close attention and make sure that we're not mistaking another effect from some other activity or other drug and blaming the suspected medicine or vaccine. So there must be that assessment. If there are effects that are rare or very rare or happens in specific populations, there may be decisions about let's not use it in that population. Or let's tell the health professionals that to look out, this is what you look for if there's an anaphylactic reaction, and this is how you manage that person if it happens. Empowerment and knowing what goes into it and what to do is going to be very important, not just for the health professional, but also for patients. So pharmacovigilance always gives us information to determine, do the benefits outweigh the risks? Because once the risks begin to become very heavy and the benefits are reduced, then we need to start making other types of decisions and looking at alternatives. So just to briefly go through, I'm not going to spend too much time and tell you about at the regional level, there is a network for pharmacovigilance, and it's designed to support our CARICOM member states and other CARPHA member states. There's some countries that do not have robust collection systems for adverse reactions or for suspected substandard products. So we've introduced a couple electronic or online reporting tools, and we send them back to the particular country. But there are also global monitoring systems. The Uppsala Monitoring Center is the World Health Organization's program for international drug monitoring. They collect suspected adverse drug reactions at a global level. Because in some countries where you have small numbers of reports, it would not be sufficient to make a strong case for acting or to rule out other issues. But when we pull everything together at the global level, we start to see more robust trends and we can make better decisions. So we assist countries that report to the center. The second surveillance system of the World Health Organization is one that warns us about falsified or fake medicines, vaccines, and other healthcare products. And with the COVID-19 pandemic, many countries have been needing vaccines, needing personal protective equipment, needing test kits. And where there is a demand like that, there's also the opportunity for criminal activity, including falsification. So that system gives, and it has an important role in helping countries note when there is a falsified product that has been confirmed, so that at the country level, they can inform distributors, they can inform those who are involved in procuring or sending to public health facilities or even private sector distributors. Our network gets support both from PAHO, but we also interact with the WHO and the national centers. But I wanted to expand a little bit. I want to go a little further. This is the global surveillance and monitoring system that I mentioned that issues the reports. And Interpol, you may have heard of Interpol. Interpol looks at global crime, and pharmaceutical crime is one key area they are concerned with. And last October, they issued an orange notice, which helps to warn persons about falsification of COVID-19 vaccines. Interpol has been monitoring online sales of falsified medicines, and in this case, they are seeing an uptick in falsified vaccines as well as test kits. So where persons may think it's convenient to shop online, it may be where it's not an authorized online distributor for a medical product, you may be interacting with someone who is engaged in criminal activity. In March, the WHO issued its first medical alert related to a COVID-19 vaccine that was found in Mexico. And this is where they tried to falsify the Pfizer-BioNTech vaccine. The person using it was suspicious they followed up with the manufacturer who confirmed this is not our product. The batch numbers were falsified, the expiry date was falsified, and they used different vials and labels from the genuine, it differs from the genuine product, which is why disposal of empty vials is really essential. They are finding that some criminals would take empty vials and relabel them. It doesn't even have to be a vial of that vaccine, but they have been found to take empty vials, relabel them, print a label, stick it on, crimp it back, and try to sell it through persons who may be desperate enough to buy. So it's important that we help protect our supply chains by reporting when something is suspicious, but also ensuring that when we're interacting or sourcing medicines and vaccines, and this may be at a later point in your career, that the supply chain that's legitimate is what is used. The other one that came out just in August relates to Covishield, and they found Covishield falsified in Myanmar, India, and Uganda. And these are three of the ways in which they confirmed falsification. In one case, the expiry date was falsified and the batch number. In another case, the volume that was being that was in the vial and on the label was a volume that the manufacturer just does not produce. And in the third case, it was a simple spelling error. They left out the I in Covishield. So I highlight these because the health professional that's familiar with handling a particular medicine, product, vaccine, get familiar with what the legitimate product should look like, because that will allow you to note when something is off. A simple thing like a spelling error is one way in which these falsified products or fake products have been picked up. So to close, keep in mind, all medicines and vaccines have benefits, which is why we use them, but they also carry risks. Nothing is free of risk. What we need to do is be aware of what the risks are before it gets to the market, make sure, benefits outweigh risks, but also when it's on the market and in use, that we continue to check, we continue to report, and we continue to assess if that risk changes or if it increases, or even if it's for a specific group that it would increase for. When you learn about the different types of delivery systems, there are things that will point out that if we use certain types of technologies inappropriately, that can cause harm. So an intravenous product will be delivered faster than something that has to be swallowed. So we have to be careful with how we administer products. At the time of approval, the clinical trials are good for giving us information on some safety risks, but we continue to look for others when the medicine or vaccine is used in the real world by a larger population. They're also going to be used with persons who may have other conditions or may be using other medicines, or it may be used in a different way than it initially was used in the trial. And that's important to learn from. So our work as health workers or healthcare professionals continues to be essential to pharmacovigilance and essential to understanding if we have any new or changing risks that we weren't aware of, and to help the regulators make sound decisions that could help protect the populations going forward. So that's what's my last slide, and I will thank you for your attention.
Okay, so thank you very much, Dr. Extable, for your presentation. Students, do we have any questions for Dr. Extable? We do have some comments in the chat about how informative, and a lot of thanks given to you.
You're welcome. Thank you.
Not seeing any questions at this point in time.
Okay.
And up next, we have Dr. Khatija Khan to talk about academic advising in the Faculty of Medical Sciences. And I know some of you would have received academic advising before your registration from Mrs. Patterson Coombs and her team. However, there's another facet to academic advising which Dr. Khan will cover in her presentation. Dr. Khan is a lecturer in clinical psychology in the psychiatry unit at the Faculty of Medical Sciences, where she coordinates the Masters of Clinical Psychology program and teaches on the MBBS and DM psychiatry program. So for students who are studying medicine, you will at some point in time encounter Dr. Khan. She also works on academic advising and mentorship and provides training for staff and students on crisis counseling in the faculty. She is also the immediate past president of the Trinidad and Tobago. So a gentle reminder to please keep your microphones on mute unless you are asked a question. And I warmly introduce to you Dr. Khatija Khan. Dr. Khan, welcome to our orientation and thank you so much for facilitating.
Thank you so much, Rihanna, for that introduction. Good morning, everyone. It really is a pleasure to be here with you today, to welcome you in so many ways to the university, to this very exciting stage in your academic careers. So I do have a short presentation that I want to share with you. I'm going to bring that up now. So I wanted to talk to you about how academic advising is going to be helpful to you and how it can help you thrive in medical school. But one of the first things I wanted us to do, well, it's really fantastic to see so many of you here today, which kind of limits our ability to interact with each other. But we'll save that for other opportunities. We're going to have more opportunities as you go along your MBBS for us to interact. So again, let me add my welcome to the many welcomes you've had so far. Welcome to the University of the West Indies. We are very excited to have you to join us at one of the premier universities, the #1 university in the Caribbean. So in addition to the welcome, I wanted to congratulate you on this fantastic achievement and to welcome you specifically to our faculty, the Faculty of Medical Sciences. So I'm going to jump straight into it because I know we're getting close to lunchtime. So you're probably starting to feel a little bit peckish. And I know you would have heard a lot of different talks already yesterday and today, but I want to highlight academic advising for you. Now, what is it? Let's get an understanding of what this process is. Well, what it is it's a collaboration between you and your advisor, and it's going to help you to make informed decisions at each stage of your undergraduate career. So you can ask questions about your degree, about selecting courses, tracking your academic performance, what the UWI's policies and procedures are, what support opportunities and scholarships, and so many other resources that are available to you. Academic advising is also a time and a place where you can engage in some self-study, some reflection, where you explore your options and what your own values and academic and career goals are. And finally, it gives you that opportunity, if you haven't really thought about it in a lot of detail before, about what your academic roadmap is going to look like for the next 5 years. Because we want you all to graduate in a timely fashion and to be successful in your stay with us at the Faculty of Medical Sciences. Okay? So this here is a model for what it looks like. So as Rihanna mentioned, you probably got some information already on how to apply or register and select certain courses. So that's one element of it, that initial advising on entry. But then you also have advising to help promote your academic success. So it may be to address academic issues. So sometimes we have students who are not successful on a course for whatever reason. And so you may need some guidance with that. Sometimes we have students who are tracking their progress or who are not sure about the next step. There's academic advising for that. You can also get academic advising regarding your career choices. And so we may host expert talks or different fora where we expose you to that. And finally, you may also need some guidance on non-academic issues like your professional development. And so what you find is that we also offer mentorship experiences. And so I won't go into that into detail today, but please know that we also have a mentorship program for you. So why are we talking about academic advising? It sounds like something procedural, but this is an important process. What the research has shown us very clearly is that academic advising helps students have greater success in achieving your education and career goals. We even find that there are higher correlations between ability and academic performance. When students have academic advising or they access it, it leads to higher retention rates. And you are more satisfied with the academic process. And it also helps you to develop more positive attitudes with your faculty and with the UE. So sounds good so far. But you know what? This road to well-being, resilience, and adaptive coping is going to be a long one. These next 5 years. It's going to be intense. It's going to be challenging, also inspiring and motivating. But there are some things that can cause you to get derailed off this path to your success. So getting derailed may lead to some mental health issues. So medical students are often at greater risk for things like depression and anxiety and substance abuse. And sometimes getting derailed on that process can lead you to do certain things that you would normally do that are not in sync with what your values are, like cheating or breaking leash, not attending class. Yeah, so we want to prevent you from getting derailed off of this path. And so we have many resources within the university to help guide you and keep you on that path to success. And you're going to be hearing about many of them throughout the course of the week and as you go along your university career. So for example, this graphic just has a few. It's not exhaustive by any means, but the UE offers counseling and psychological services, financial services. We have support for academic support. If you have a disability, we offer support as well. And of course, we offer academic advising and mentoring. And that's where I'm going to keep my focus. So again, academic advising helps you to make the best decisions about your program. And it also signposts you to the relevant resources within the university. So who are academic advisors? Well, there are 2 levels. So level 1 advisors are administrative staff. And you would have encountered them via email. For example, Rihanna, who is hosting us today, she's administrative staff, so she would be a level 1 academic advisor, level 1 academic advisor. And then we have level 2 advisors, and these consist of your academic staff. So your lecturers, your course coordinators, etc. So academic advisors within the faculty share some common traits. So they are knowledgeable about the UE and its policies, rules, and guidelines. And you know what? In case we don't know, we can help you find out, or we can find out for you or guide you in the right direction where you can get that knowledge. Advisors also help give you guidance on what information, what resources you need, and what next steps to take. So the idea is that we don't want you to feel frustrated because you're unsure about something. We don't want you to feel nervous or anxious because you're fearful of doing the wrong thing. Seek out your academic advisors, seek out the assistance of the faculty, and we will help to guide you. Yeah? And this process is also collaborative. So if you have an opinion about something, if you're concerned about something, we want to hear what you have to say. This is not This information flow is not only one way coming from your advisor to student. It's a two-way flow of communication. So we value your opinion and we engage in collaborative problem solving together to help you find solutions. Okay? And you know what? We genuinely care about you and how you're doing. We want all of you to succeed. We want you to achieve your fullest potentials. Many of us are in this job because we care about students. We are passionate and we are invested in your well-being. And even if you are not in my specialty, I still am interested in you and your well-being and your success. So for example, I'm a lecturer in clinical psychology, and you will encounter me in if you're doing the MBBS, you will encounter me in year 4 when you do your psychiatry rotation. Some of the other students, you will encounter me when I do some of the training across the faculty for students in general. But even though I'm a psychologist, I care about all of you. I'm invested in all of you. And this is what academic advisors do. So whether you're in vet, pharmacy, optometry, dentistry, we are concerned with all of you. Okay, so you do not necessarily have to seek out academic advising only from your unit. That's a helpful place to start. But if you also seek guidance outside, there are others who can help you as well. And while we are encouraging and caring and supportive, guess what? We also hold you to standards and expectations, because that is what is going to help you succeed. Yes, so we hold you to standards that you probably hold for yourself, because this is the key to your success and to thriving in medical school. So you may come to an advisor with a range of issues, and we know this about students. So while I've mentioned, say, academic, sometimes students have concerns about different kinds of issues. Maybe they're questioning, what their values and goals are professionally, what their career plans might be. Maybe they're having some issues with some peers or some classmates. Maybe you're having a personal issue. It may have to do with your family situation or your relationship, and it's affecting your ability to function at school. It may be physical. You may be having a health issue. You may be having an issue with the facilities on the campus. Whatever the nature of your issue is, we want you to know that we welcome you to seek guidance, to ask questions, to find out more. There is nothing you can't ask about. Okay? So for example, here are some hypothetical situations. While they're hypothetical, well, I won't say they're hypothetical. I'll say these here are anonymized because all of us have experienced these concerns in students over the years at some point or another. So at some point we do have students. So here I have a hypothetical fan who is having second thoughts about medicine and she does not know if she wants to continue with the MBBS program. Now, at face value, that might seem like Fianna is having a personal issue, but because it's related to her career and her studies and how she progresses through her career at UE, academic advising could probably help her. So we would encourage Fianna to reach out and talk to someone. What about Cass? So in this situation, sometimes students face tragedies. Life happens. We are dealing with a global pandemic, and it has created so many additional stresses and strains of different levels and different intensities. So in this situation, we have a student whose family member has passed away, and it has had an impact on them as we expected would. So he has been able to eat, sleep, or concentrate, and he has started missing classes. And he does not know what to do. He is struggling to cope. And we want you to know that if you're struggling in any way, please reach out. seek out your academic advisor and they would be able to signpost you and help you to access other resources. How about Marshall, who here too, hypothetical nursing student. His family income has decreased in the pandemic and now he's not sure he can afford tuition and rent for next year. He is also very worried and doesn't know what to do. Even for a situation like that, please speak to an academic advisor. The university has some options for you. On a previous slide, I showed you that you can get some financial advice. We do have some emergency funds that are available. There are scholarships that are available. So please, no matter what the situation is, academic advising can help. And sometimes we have students who are not successful the first time they write a course. And especially many of you are high achievers and perhaps you've never failed a course before. So the first time this happens, it can be a really disorienting and distressing process. And you know what? We're here to help you through that as well. Sometimes you might fail a course and that does not mean anything. It means that you may have to repeat a course, but it certainly does not stymie your goal of graduating successfully. But to help you know what the next steps are, if this should happen, academic advising is the key. So again, just to refresh your memory, in any of the situations, we have a lot of resources available at the university, and academic advising is one of the key gateways to help you access. So in case you're not sure what's available, your academic advisor can signpost you in the right direction, and then you can go on to access more resources from the university. All right? So apart from that, so I mentioned that Rihanna mentioned as well that I also do training for the entire faculty, for students and staff. So for example, on the left, that was an example of a training we did a couple of years ago. Sometimes students struggle with group work. Have you ever been in a group project? You know, sometimes the dynamics can lead to a few conflicts, and you will engage in group work in your stay at the university. So we do have a workshop on becoming the best group leader ever. So this one was targeting group leaders, but anybody could have attended, and it was aimed at helping you to understand some of these group dynamics and how you can conquer them. This other workshop on the right was for training of staff. So we want to ensure that our administrative staff and our faculty have the skills needed to provide you with the best academic advising and mentoring. We want the quality, we hold ourselves to high standards as well. So we want the quality of the service we deliver to be high as well. So we conduct training for that. But we kind of talk about, now every year I give this, I give a presentation on academic advising to new students. But we're in a different scenario now. We're in the midst of a global pandemic that has drastically affected how your education is being delivered. I'm sure when you dreamed of entering medical school, it was not in this way, where we'd be speaking to each other through a screen. You probably imagined visiting the campus, being in a large lecture hall, being in the labs, being on site. But that has not happened, and it may not happen until it is safe for us to do so. So what we realize is that because of the stresses that the pandemic is posing, it has caused a lot more anxiety and uncertainty in students. And we know this and we recognize this. And so we want to preempt some of this in you. So academic advising in this COVID era will also focus on helping you keep abreast of all of the changes that may occur as it relates to your program, or things concerning assessment, like your exams or your assignments. We want to know what your concerns and needs are at this time. So for example, we've also been doing research to find out more about your needs your readiness, your capabilities to engage in online learning to see how best we can support you. We also want to provide prompt support, because when you're anxious and uncertain, that can derail some of your decision making. And so we want to provide you with support in a timely manner to help you make decisions. And we also want that information to be accurate. You know, this is the age, this COVID-19. Oh, and I have a typo there. It's not the COVID-9 era, but the COVID-19 era. You know, it's fraught. And we just need to look at social media, look at what's happening in conversation in society, and we know that it's fraught with misinformation. And so we don't want you to be subject to that as it pertains to your UE studies. So academic advising also helps provide you with accurate information in a timely manner. Okay? And to help provide some of that support, as I said, we know that this pandemic has been stressful for our students, and so we do offer support of different kinds. So these are some examples of the sessions that we've done over the year, aimed at helping you with your psychological well-being, your resilience to cope with the challenges that you will face and to rise to those challenges so you can fulfill your best potential. So some of them were aimed at tackling anxieties, and some were aimed at coping in general. And sometimes we do it for specific groups of students like dentistry or vet, or sometimes we do them across the whole faculty because of course you have shared concerns. Okay. And I just wanted to pause here to just mention very briefly mentoring. So we have an academic advising and mentoring committee in the faculty. And while advising may focus a little bit more on the nuts and bolts of navigating the system, mentoring focuses more on your personal and professional growth and development and that big picture. And so you will hear more about mentoring and the opportunities to access a mentor within the faculty later on in your stay with us. Okay? We know that mentorship is also important because it helps you with your professional development, it helps with your career planning, it helps turn you into researchers. So people who don't just use research to inform the quality of service they deliver, but those of you who might be active researchers who produce research. Yeah? And it also helps for persons who are underrepresented in medicine. So for example, certain fields may be dominated by certain genders, or certain fields may not be as prominent in the Caribbean. And so we found that mentorship can help improve some of these outcomes. Okay. So in wrapping up, I want to remind you, communication is going to be key. It's going to be critical in this era to help you get all of the information you need to help you feel more confident about this process. So I encourage you to check your UE email frequently, use your virtual learning environment, become familiar with the faculty's website, with the university's website, so you know where to access the information you need. And I also really encourage you to stay connected and reach out. This is advice and guidance I've been giving in general to anyone during the pandemic, but specifically for you here as you start this journey with us. Stay connected, keep open lines of communication. Know who the key people are in your school, in your program, that you need to be aware of, that you can reach out for guidance. And please do not be afraid to ask questions. We welcome questions. We prefer you ask a question when we get the opportunity to help you rather than you are uncertain and are not sure. Okay? So here's our philosophy, and I want to end with that. We make the assumption that every student can succeed and every student has strengths. So all of you can succeed, and we know all of you have strengths. So we approach every academic advising interaction as an opportunity to help you manifest your true potential at the UE. You are all a light rising from the west. You can do this, and in 5 years, I look forward to seeing you all graduated successfully. And if it's not 5 years, you will do it in your own time. So again, welcome, congratulations, and all the best to you as you navigate this journey. Thank you.
Thank you much. Thank you very much, Dr. Khan, for that wonderful presentation. I'm having some technical difficulties with my internet as well, so I'm hoping you all are hearing me okay. We have everyone in our chat sending their thanks to you as well, Dr. Khan. So students, you see the importance of the role of academic advising in the faculty. These workshops that Dr. Khan usually facilitates are a lot of fun, it's a lot of learning. You know, even though we had our curve of the pandemic with having everything to be online, you know, at least with some of these workshops, we can even accommodate more students, right? And we send out notices to the group leaders, to the different student reps, you know, when these sessions are to be held, and you all can look forward to doing that at some point in time in your academic future. So I'm not seeing any questions. Dr. Khan, we do have a lot of commendations about the gifts and the Soka family names. The students love that. So I'm seeing everyone talking about that. We have someone who said she felt like she could have related to the cat on the laptop. I can also relate to that. That was quite interesting. And at this point, we have no more questions. Yes, Doc.
Rihanna, I have 2 questions, and perhaps the information. So because they were direct message, I'm not going to say the names or anything, but the information I think
sure.
So for financial advising, can we post some information for students? And
we actually do have a session on Thursday at 11:30 with Gate and the bursary. Right? So we have Mrs. Lovelace. She will be representing Gate. I know students would have questions regarding perhaps funding, scholarships, applications. So we have an entire segment dedicated to that.
Great. And one more question, dentistry. If they have not had advising yet, who might they speak to in dentistry?
I believe Mrs. Cheryl Gomez, the administrative assistant, will eventually reach out in due time. The director, Dr. Smith, can also advise further. I did have emails coming in from students who were a bit concerned that they had not received their academic advising. What I can say is to just hang tight, and at some point we will get to you. It's online, it's limited staff, and it's, they're trying to do it as best as they can. So just have a little more patience, a little more time. You will get that email, you will get that call, and everyone will eventually get an opportunity for the academic advising to the program to which they are interested in and have registered for.
Okay. Another question, if they have a hold and which is not allowing them to register, how long might they have to wait for the hold to be removed?
Okay, so Mrs. Patterson Coombs, she's our senior administrative assistant in the dean's office. She deals with our financial matters as well as academic holds. So perhaps students can wait a bit to see if the hold is removed after their advising, or they can send an email to Mrs. Patterson Coombs and she can take it from there.
Okay. And final question, who does one email or talk to about possible exemptions from courses? Might they wait until they hear from their school or program and then follow up through there?
Correct. They can wait until they get the relevant. Well, that is all part of academic advising, right? So what they can do is they can wait until the relevant administrative assistant reaches out to them and explain to them, what they have qualified in and if they can apply for the exemption and the process from there.
Okay. And then final, well, I said that was the final, but one final. So someone is asking about the services I provide. So I provide services to the faculty through the Academic Advising and Mentoring Committee. And Rihanna is the administrator for that committee as well. So especially if there are any groups of students, for example, I mentioned that group dynamics workshop or the anxiety workshop. So if you're interested in a service, please reach out to the committee. So you can reach out to Ms. Ramakasing, or I'll put some of you have asked for contact information. So I've just put my UE address there. And you can reach out and we'll help as best as we can. So thank you. So one more question, Rihanna, I'll have to say it because it's coming direct message to me. So I know you won't be able to see it.
Sure.
Do we have access to their class timetable?
The timetable is actually up on the FMS website. I can send a link to the timetable in the chat here, and you all can download the timetable from there. So we have one other question in the chat that is unrelated: access to orientation recordings. Yes, it would be played on the UE YouTube station, and you can play it back. I will be sending out some more information regarding the playback for the recordings of all the sessions that took place during the week.
So all the best to you all, and enjoy the rest of your orientation week.
Miss, you're very pretty. Okay, bye.
Okay. So as Dr. Khan mentioned, I'm also the secretary and the administrative person to the Academic Advising Committee. So that's, anybody with questions related to academic advising, you can feel free to reach out to me, send me an email. Just bear in mind that all staff members are currently working remote, and sometimes we may not be able to respond to emails right away. We have another person in the chat. Once again, okay, I'll deal with questions in the chat after, right? Up next, we have another presenter. We're a little bit ahead of time, so that's not a problem. Dr. Simmons. Is Dr. Simmons logged on? Okay, so I will give a brief introduction, students, about Dr. Simmons. Dr. Varel Simmons joined our Faculty of Medical Sciences in 1995 as a part-time lecturer in the School of Pharmacy. In 1998, he was appointed a full-time lecturer in toxicology in the School of Veterinary Medicine. He has lectured to students in the Bachelor of Sciences for Pharmacy, Medicine, and Dentistry programs, as well as tutored students of these programs in the PBL learning for about 2 decades. Dr. Simmons has also served on the curriculum committee of several programs within the faculty. I now extend a warm welcome to Dr. Simmons and thank you for facilitating us today. I hand over to you.
Are you seeing my screen?
Yes, we are.
Okay, so this morning I'm going to speak on the issue of learning styles, and I've subtitled the presentation, "I Don't Think That Way," and I hope that by the end of the proceedings, you will get a sense of why I chose that particular subtitle. The learning objectives are, firstly, to understand what a learning style is, understand how, as students, we learn best, and to know how to study to our particular strengths. And at the end, I've thrown in, I hope, some food for thought and some little tips that I hope you would find useful. For starters, I have attempted to address the issue of learning style theory. And now learning style theory really focuses on the process by which we input information, we internalize and that information, and also how we communicate this new information. The key takeaway from all of this is that learning style theory implies that it's not how much an individual learns, but rather the quality of the educational experience that really determines their ability and capacity to learn. And by quality of the experience, we are speaking to the particular style of learning. So the whole concept of the smart or not too smart student is thrown out the window, as it were. What is a learning style? And I've got varying definitions here from very smart people who you can go back and look at. But basically, the learning style speaks to predisposition on the part of some learners to adopt a particular learning strategy regardless of the specific demands of the learning tasks, so that you find that most students have adopted a particular strategy that they use to process information, and it really doesn't relate to the specific demands of the particular learning task. Now, this is a pretty simplistic way of approaching it, because in the final analysis, most of us use a mixture of strategies. But you would find that if you examine your particular strategy, that one or sometimes two predominates. And we'll have a look at the data in a little while. So another bright person was credited with saying, "I never teach my pupils. I only attempt to provide the conditions in which they can learn." So again, critical to the learning process is providing the conditions, providing the space, the formatting the material in a particular way that promotes learning. Research has shown that students, a particular student's learning style is allied to their performance in different learning environments. What we find is that as a student, you will have adopted a particular learning style when you were at the CAPE level, and even within the professional schools that you each would migrate to from next week, we find that from the first year to the final year, the individual student's learning style is modified to compensate for the different learning environments in which they find themselves. So the learning style that dominates or predominates in the basic sciences may, and in most cases, does change when they get to the clinical part of the program. Perception of the learning materials and the format of the presentations is influenced by the student's particular style, learning style, or learning preference. Again, if you look back, you would find that you gravitated towards a particular teacher. Now, the teacher may have been, you may be comparing several teachers who taught the same course. So let's take mathematics, for example. You may have had a different teacher in junior school as compared to middle school. And you found that you preferred mathematics when it was taught by one rather than the other. And if you really examine the whole process, you would find that what influenced your concept as to how easy or difficult the subject was, to some extent depended on the format that the particular teacher adopted, as well as the approach to presenting the material. And that's part of the learning styles. Ultimately, and your awareness of your learning style provides you with information that can inform the particular strategy that you're going to adopt to learn, to assimilate the information, and ultimately it enhances your learning. Now, I've spoken a bit about learning styles, and I want to administer a questionnaire. Now, this questionnaire is based on 4 modalities, basically. And what we hope at the end is to identify your individual preferences. Now, you can download the questionnaire at this URL, and we will take about 10 minutes to complete the questionnaire and to grade the questionnaire. So if you can go to that, okay, I'm hoping that by this time, most of you would have completed the answers, and you are permitted multiple answers to the same question, multiple selections. And I'm going to give you the answer key or the scoring chart. So for example, for question 1, if you answered A, then that is 1 point in the K category. B would be in the A category. If you answered C, it would be in the R category. D would be V. And at the end, we are going to count how many Ks, As, Rs, and Vs that you have over the 16 questions. Okay. So in terms of the learning style, the style that you just attempted to categorize yourself by is called the Vac style, V-A-R-K. Vac is an acronym, and it stands for visual, oral, that's oral with an A, not an O. The R would be reading, and here reading is synonymous with writing, and the K would be kinesthetic. There are many individuals who use several of these styles, and they are considered multimodal. So VAC has its origin in neuro-linguistic programming. And basically, this theory suggests that we receive information via the visual, that's the eyes, the oral, which would be our ear, and the kinesthetic, roots. And this is the manipulative, the hands type activity that comes under kinesthetic. So down the left-hand side, I've tried to summarize them, and I've included read, write, because that is an important modality that oftentimes we use. Why the VAC learning style? Well, firstly, it offers a positive affirmation of the learning ability of all students. Secondly, it encourages the belief that everyone can learn. The only caveat is that one's learning preferences need to be addressed. But we do ultimately believe that everyone can learn. The VAC inventory is short. It only comprises 4 elements, and it's simple to use. And as you would find, the questionnaire does alert students to the variety of different approaches to learning, as well as identifies their individual learning preferences. Using this model, students can be provided, those students who have difficulties with learning can be provided with support, because it identifies some of the reasons why they may be having challenges, and therefore what can be done to address those challenges. And last but not least, this style can be used with a group, with a class, or in a one-on-one type setting. So it's extremely versatile. Strategies that you as a student can adopt will assist you in the areas of taking in information, studying that information so that you become effective learners, you minimize the time you spend learning while maximizing the amount of information you absorb in that time. And I think something that normally gets most students excited, it allows you to optimize your study in such a way that you perform well in examinations. And this is the giving out of the information. So you're taking in information, you've processed that information, and now you are outputting that information in an examination setting. So let's talk a little bit about the different preferences. Students who have a visual preference would find that they like information presented as maps, charts, graphs, organized in flowchart type of settings. That is something that intuitively you migrate towards. It's not something that you necessarily would learn or be taught. Strategy that students who are visual would adopt in terms of their study habits would be to draw flow diagrams. These days we speak more about mind maps. So you do mind mapping of the information that you need to understand and learn. And these visual students find that this helps them to process the information better, to understand the information, etc. And I've done, and there's a graphic here of a mind map related to the effects of COVID-19. And you can see very basically, the map identifies 5 different areas that impact on, that are impacted by COVID-19. We speak about politics, the economy, education, health, socialization, and then using each of these, you can go into subheadings, etc., and that assists the visual students in absorbing all that information in a meaningful way that they understand. The oral or auditory preferences are exhibited by those students who process information that is heard or spoken best. So these are students who learn best in lectures or tutorial type settings, where information is recorded, like podcasts, etc. They do well in group discussions, web chats, etc. These students also find that talking out loud assists them in understanding and retaining information. You may recall that among the English literature teachers in primary school, this was a particular, this still is a particular strategy that they use, where you repeat poems, and that way you retain them. I'm not sure about the understanding, but you certainly retain them. And often persons with this oral preference, you find that they want to sort things out by speaking rather than sorting things out and then speaking. So they don't rationalize it and then produce the output, but part of their rationalization, part of their internalization of information involves speech. So as a student, the strategies that can be used would be discussions with other students, and you would find here that the PBL, which is part of the learning approaches in the faculty, are going to be very beneficial to these types of students. And also they can make tapes of the summarized notes and play those tapes back again as an aid to learning. Those who have the read-write preferences want information displayed in words. You would find that many academics have a strong preference for this modality. This emphasizes text-based input and output, so reading and writing in all forms. These are those who would sit with their textbooks or lecture notes in front of them and read the material and internalize it that way. These persons are the ones who are addicted, in quotation marks, to PowerPoint, the internet, lists, dictionaries, quotations, any form of words. They have a strong preference for. So the recommended learning strategies, if you are an R type, would be to condense your lecture notes into lists. So you'd find that you take 3 pages of lecture notes and you condense it into 1 page with bullet points. and use discussion sites. These sites may be online. So we do have now group chats where your classmates interact. You ask questions, and if the opportunity presents in face-to-face, you ask questions of your lecturers, and where the situation permits, you engage with face-to-face discussions with other students. So in addition to the online discussions, you also would find that you benefit from the face-to-face type interaction. The fourth category are those with the kinesthetic preference. And these are persons who learn best through actual reality-based scenarios or simulated scenarios. So whether it be personal experiences or shared examples, and the practice or simulation type exposure that occurs in laboratories, these are the modalities that these types of students prefer to be exposed to the material. So demonstrations, simulations, videos. So this is where the YouTube type scenario plays out for those with the kinesthetic preferences, case studies, and the ability, as I said, to practice and actually model some of these applications. These are the areas that these students do well in. And the recommended strategies would be to maximize the use of your clinical or practical experience. So you would find, for example, that in this particular scenario, a third-year clinical student may tell a second-year clinical student that the skills lab was a waste of time because that student was not particularly, the third-year student was not particularly kinesthetic and therefore didn't maximize the learning opportunity that the lab presented, but the second-year student may be kinesthetic and would certainly benefit from that laboratory exposure. The use of case studies and real-life scenarios to make learning real. A lot of students, in my experience, remember a particular scenario that somehow caught their interest, and a lot of the information related to that, they find they don't have to revise it, it somehow has stuck. The practice of applications of theory, again, and the use of role play, all of these assist the kinesthetic person in the learning process. So using the VAC model, we can look at the student's success space as involving these four modalities, and then each modality, you can see that there are particular strategies that the student finds most useful, most beneficial. I did speak to the multimodal preference, and life is really multimodal. Life is not neatly compartmentalized for us. And you'd find that There are seldom instances where only one mode is used, or really only one mode is sufficient. So you find that the vast majority of you would in fact have a 4-part VAC profile. Some parts of the profile may be more strongly emphasized than the other, but you'd find that each of the 4 does contribute to your learning system. Studies show that those who prefer many modes almost equally are of 2 types. There are those who tend to use a single mode to suit a particular occasion or situation, so it's context specific. In a particular context, they would use one mode, and in another context, they switch to another. And then you have other students who are not satisfied until they have had input or output in all of their preferred modes. These multimodal students generally take longer to gather information from each mode, and as a result, tend to have a deeper and broader understanding of the subject matter. Another wise man summarized this type of learning by saying, I hear and I forget, I see and I remember, I do and I understand. That was Confucius. For Confucius, the oral mode was not particularly helpful, but the visual and kinesthetic were very important. From the VAC website, about a decade ago, they looked at almost 60,000 students, and you'd see here that about 37%, just over 1 in 3, have single preferences. About 15% are bimodal, that is, they have 2 of the 4 modes that they use regularly. 12% would be trimodal, and 36% used all 4 modes. And you can see even among the single preferences, the unimodals, there is some variation in terms of their preferred modality. So it doesn't matter where you fit in, there's room for all. I attempted next to look at some of the professions in our faculty and the learning styles of the students in those programs. So this is one for nursing students. And you would notice that in the unimodal, almost 20% were kinesthetic. The bimodal, about 23%, about 22% were in the quad modal, all 4 modes, and about 13% trimodal. For dental students, we're seeing here, again, just about 37% in the unimodal, and you would notice that for the bimodal, there's a little bit of scatter, but again, when you get to the quad modal, we are at about 24% of the student body. So again, there is there is some scatter. This was one done on undergraduate medical students. I think this was either first or second year medical students. So unimodal, this was first year medical students. So unimodal, which would be the right-handed pie, about 47% of the students identified as unimodal. About 37% identified as bimodal, 11% as trimodal, and about 6% as quadmodal. A very different picture to the other groups we looked at earlier. And I think this has been really a result of the transferal of the secondary school experience, or the perceived modality that was used in secondary school coming into the undergraduate program. As we said, this is self-perceived. I'm sorry for the quality of this slide, but this paper looked at the percentage of students in the health professions and how they scored on the VAC learning modality. So this would be all-encompassing, and you'd notice that 62%, so that's the left-hand tower, 62% were multimodal, so that's 2 or more. And among the unimodal, we see the towers building from left to right, 1% visual, 6% oral, 16% were the read-write, and 15% kinesthetic. So the vast majority, as you would have gathered from the earlier studies, the vast majority are multimodal. There are some important cautions or cautionary notes that I have to add. Firstly, preferences are not the same as strengths. Your VAC results, which I hope that you all would have had now, your VAC results merely indicates your preferences and not your strengths. Having a low score for, say, read-write does not mean that you cannot read. Secondly, you need to focus on your preferences. We do not recommend trying to improve your use of your lowest score modalities, which in effect means going against your preferences. And that's not likely to be motivating. Thirdly, remember that VAC is about learning, not about leisure. VAC is about learning, not about leisure. So there are persons with a 0 score in their VAC profile under, say, visual, but these persons enjoy relaxing by drawing or painting or visiting art galleries. So this is about a preference for learning. It doesn't speak to your preference for anything else. One of the things that we sometimes encounter is that the VAC questionnaire is not completed correctly because some students are intimidated by the environment. And secondly, your preferences may be masked by your life and work experience. So all that we ask is that you understand, you go off, you can read up what each modality means, and therefore how best you can optimize your reading style. One of the positives that has come out of this exercise is that when you are aware of your own learning style and the particular strategies that are best, learning strategies that are best suited for you, it does transfer into better success at exams. So to summarize now, what type of learner are you? You've done the assessment, and what you would find when you total your V's, your A's, your R's, your K's, it gives you an idea of where your strengths lie. So the fact that you may have, say 14 V's, 2 R's, 16 A's, 0 K's, points to strengths that you have, and therefore the relative strategies that you should maximize when it comes to learning. There are 5 take-home points. The first is everyone learns differently. Secondly, if you know your learning style, you can be your own favorite teacher. Thirdly, remember your learning mode or modes and embrace the methods that work for you. Ultimately, remember that effective learning is more than just reading and writing. John Dewey, a famous educator, pointed to the aim of education should be to teach us how to think rather than what to think. The aim of education was to enable us to think for ourselves rather than load up our memories with the thoughts of other men. Peter Drucker, a more modern thinker than Dewey, came along to a similar endpoint. Drucker says, we now accept the fact that learning is a lifelong process of keeping abreast of change. And the most pressing task is to teach people how to learn. So with that, I thank you for your attention and invite any questions that you may have of me.
Okay, Dr. Simmons, thank you so much for that presentation on learning skills. It's always fascinating to know what matches you best. At this point, I'm looking in our chat. I'm seeing a lot of students sending their thanks to you and their gratitude. However, I'm not seeing any questions. Students, this is your perfect opportunity to ask any questions to Dr. Simmons. If not, the faculty once again would like to thank you for your presentation. And students, do remember that this can be viewed once again on the YouTube channel. I will send you the links on the last day of the week with all the sessions so that you will be able to access it. We have no questions for you at this point in time, Dr. Simmons. A student has mentioned that you have cleared up everything nicely. So students, that brings us to the end of orientation for today, Tuesday, the 7th of September. I do wish everyone a wonderful day. Please keep safe. Tomorrow we resume again at 9 a.m. and up first on our presentation, we have an introduction to PBL. So thank you. You guys can go eat your lunch and enjoy the rest of your day. Take care.